Oh, hey, Chris.
Hey Chuck, how are you?
I'm really good. How are you?
I'm great. I'm great. It's a Saturday. It's rainy, so it's nice to be inside. It's, I think, starting to get warmer here in St. Louis, which will be great.
It is. It's welcome. It's been an interesting winter. What are you doing this fine Saturday morning when you're in the office?
I am going to be lecturing our residents. Those of you who've been listening for a long time know that we usually record a podcast when I'm coming in to give resident research lectures. So our residents have a very nicely designed research curriculum designed by Dr. David Bergen, our partner, who runs that. So I'm giving a lecture about grant writing today, which I need to do more grant writing because my grants keep getting rejected at this point. It's hard right now, man. I'm in a bit of a dry spell.
It is hard. I did have the really sad occasion to miss our fellowship interviews, and what a bummer. And I've not missed a fellowship interview in my 24 years. This was the first time, and I really was disappointed. But I heard it was an amazing day and so many really qualified applicants.
Yeah, an incredible group. I mean, future of hand surgery is bright. We say that every year, but it really is. I mean, just such an incredible group of people. We interviewed 31 people, had just really impressive accomplishments to date, and we know that they're going to go far. We only have 3 spots, but I wish we had more, because I think that it'd be great to just provide more opportunities for people who want to be here. But yeah, incredible group, very well run day in terms of a classic WashU interview day in terms of down to the minute. And we were able to get people out early, which I think is important. Although we did start early, we didn't start any earlier than our norm. So it was a great day. And, I think um, everybody had a good time. So we're sad to have missed you. It's an impressive streak of 24 years, but some things can't be changed.
True, true, true.
I mean,
Uh,
even LeBron's all NBA streak ended. I mean, it's
it's right. It's
after
right.
I think probably about 24 years. So
Yeah, oh my God. Well, before we jump in, we have a clinical topic we want to hit hard today. But The Upper Hand is sponsored by PracticeLink.com, the most widely used physician job search and career advancement resource.
becoming a physician is hard. Finding the right job doesn't have to be. Join PracticeLink for free today at www.practicelink.com/the upper hand. So I wanted to say thank you to those of you that have left reviews on iTunes and Spotify, wherever you get your podcasts. 5 stars, of course. I will say we're not allowed to give medical advice directly to patients on the pod. So we appreciate those that have emailed in or left YouTube comments with queries and also left something in the your 5 star review. But we can't give advice directly to you, unfortunately, for so many reasons. But you're more than welcome to seek out Dr. Charles Goldfarb if you want to come in for a visit in St. Louis.
You know, I'm going to go off on a tangent. I apologize. But I recently I used Chat GPT to search for a topic, and its response, and I think most of us have read that, yeah, it's pretty good. AI does a pretty good job and can be helpful for patients. But it gave me an answer which I didn't think should have been prioritized the way it was. And really, it has to do with how, and maybe this is a topic, a totally separate topic that we need to hit. But it gave me an answer that I didn't think was where it should be. And so, yeah, let's talk
Do
about this
tell.
some.
Do tell. What did you ask ChatGPT?
Well, I asked it, how would you, it was actually, it was kind of a leading question was, how would you recommend my child be treated for radial deficiency with a deviated wrist? And it gave an answer which is not generalizably acceptable and accepted by a surgeon who does some things that most of us wouldn't do. And so I went down the rabbit hole. And, again, this is a whole topic. But, we always talk about search engine optimization for like Google searches, but AI works in a different way. They work on retrieval augmented generation or RAG, and it's a web search and it's prioritized differently. And I've talked to our people about that we have to start transitioning how we think about people searching for us. And it's led to this again. We could talk a long time. This could be a whole episode. But I'm going to go hit my blog again and do some different things with my blog and refresh some pages because this patient-centered process that a blog represents, I think is really important in this day and age with AI searching the web differently than Google searches the web.
So it's a whole different SEO, search engine optimization. It's not even a search engine anymore. It's how you get ChatGPT to pay attention to your content, basically.
Exactly. Exactly.
Yeah, there is a very controversial and at least well known on the internet, brachial plexus surgeon who does things differently than most people, put it that way. And for a lot of nerve things, does a lot of direct to consumer advertising on Facebook, et cetera. Who I think dominates a lot of the search engine and ChatGPT or AI generated responses. So it
Yeah,
happens in all of our fields.
it's kind of frightening.
Mhm.
And it's just one more example of science getting pushed aside. But, we have to own that we need to do things differently. And, I don't treasure the idea of going back to old blog posts and refreshing them and writing some new blog posts. But I think that's what I need to do.
Hanging on to the blog. I commend you for that, Dr. Goldfarb. So impressive.
All
So I
right.
wanted to talk today about a pretty common topic. I was giving a lecture recently, and it was about volar plating for distal radius fractures. So I think in general, we use volar plates a lot to fix distal radius fractures. Before we dive into kind of technical sequence and approach and all that kind of stuff, like when do you not use a volar plate? Like, are there particular fracture patterns in which you say, "Hey, I don't really think this is the right one"?
Yeah, great question. This is such an important topic that we haven't touched on in a while, so thank you for bringing it up. I think there's probably two occasions where a volar plate either might not be my first choice or might not be appropriate. So the first, and whenever I do this, the fellows comment, I think there's somewhere closed reduction and pinning just still makes sense to me. And I might be a little bit of a dinosaur in that approach, but my gosh, in a simple Colles fracture or distal radius metaphyseal fracture that is unstable, especially in a thin patient, and in a situation where we can get away with 2K wires. And I just think it's crazy that sometimes we don't do that. The morbidity is less, the recovery is the same or shorter. You can still put the patient in a brace and let them move. So that really simple case that you are doing surgery on only because the instability is too much is one that I think about. How do you think about that?
I guess we don't disagree enough apparently. Well, at least we got that comment like right at the beginning. I don't know if people still feel that way,
True.
but I don't know if I would have the same confidence in my early motion protocol with 2K wires as opposed to a volar plate. So I would probably disagree with that. I agree that yes, in certain populations, obviously, pediatric being the one that comes, top of mind. Yes, but I think in an adult population where part of the consideration for surgery is an earlier return to activity, I probably would not have the same level of confidence. Now, clearly, in kind of different situations in which it's more of a temporizing measure, maybe that's the case, and if you end up keeping it, great. If there's a polytrauma, et cetera, but even in a polytrauma, you're going to want some kind of higher level of stability and confidence for whatever weight bearing you need to do. So I don't know. I don't. I personally, the last time I pinned an adult fracture, I was maybe with you in fellowship, if you were doing it then. But kids, I think are different.
The kids are different for sure. And let's just put it in context. I don't have a particularly trauma heavy practice in the sense of distal radius fractures. I do a lot of athletes, but kind of the middle-aged or older patient with a fall, I do less than 50 a year of those cases, and only one or two would I pin. So not common. The other situation,
Do you feel like we could pin in the procedure room? I mean, I think that's another consideration. If you have somebody that's there, and in terms of we've talked in prior episodes about access, do it under local, do a pinning in the procedure room because I know there are practices in which fractures are being pinned in the ER and in procedure rooms.
yeah, I haven't ever penned a radius. I wonder how one would get sufficient anesthesia. Might require multiple nerve blocks, and not just site of insertion, obviously. It would be amazing if we could do that. I don't think in our situation we could.
Okay,
I don't
just
think.
food for thought. If any listeners do a fracture, I mean, I know that there's a lot of talk about like wide awake volar plating. So yes, it would require a lot of very thoughtful and tedious nerve blocks. But we know the anatomy just as well as anybody else. So
I recently did my first dorsal wrist ganglion local only anesthesia case, which went fine. Patient, found out that they needed to do it under local. for health reasons, and we did it. And it was fine. Have you done a distal radius? I mean, a dorsal radius ganglion?
Yeah, I think I have. I didn't enjoy the process, but I did it because, that's what the patient wanted. And I was like, I can do this. I will not enjoy it more. More and more I use Volant when it's either advantageous to the patient or it's advantageous to me, not just to say that I did it.
Yeah, yeah. All right, sorry,
So
getting off topic.
when else will you not use a volar plate?
I mean, certain open fractures, which are very uncommon, if there's a lot of joint involvement. Now, one could argue that a volar plate is probably good enough for most, multi-fragmentary intra-articular fractures, but sometimes going dorsal in those situations can be really helpful. And so those sometimes those I'll go dorsal, open dorsally. But listen, if I have those 50 distal radius fractures in a year, probably a similar number, one or two, do I go dorsal on?
Yeah, during the fellowship interviews, I showed a case where I went dorsal. It was the classic kind of dorsal ulnar corner fragment, but it was good for discussion because there was somebody who in our group who thought you could capture that piece. It was a pretty sizable piece with a volar with a screw through the volar plate. For me, I mean, I think that the really bad, very unstable radiocarpal dislocation type fractures, the high energy ones in which you're thinking about a spanning plate anyway. I think that's one. And I think there are a number of fractures which are higher energy that maybe don't warrant a spanning plate, but maybe not a volar plate alone. So maybe it's something to stabilize the lateral or the radial column, either with pins or with a radial column plate. I think, so the volar plate alone probably can't help with that. Then there's always that kind of pesky lunate facet piece, the Barton piece or any of those variants, in which you can use a volar plate, but I think you have to be a bit thoughtful with how you use it or you can augment something in addition to the volar plate. So yeah, I mean, do you have any feelings about that volar lunate facet piece?
Well, the volar lunate facet to me is best treated volarly. Um, B, the first step is recognition, which sounds like a silly thing to say, but I think a lot of times when we have a failed treatment of that fracture, it wasn't quite so apparent on the initial radiographs, and so it's not appreciated initially, therefore not treated appropriately. And then lastly, I would say standard volar plates are not appropriate for most of those fractures. So it needs to be some modification of a standard plate or a fragment specific volar approach, not your typical volar plate. Is that how you think about it?
Yeah, and then I think a lot of manufacturers have different, either something that goes on top of their plate or a different plate in and of itself that is targeting that piece. And then you can also just go old school and fix it with an independent screw, with or without a washer, in addition to a volar plate for the more metaphyseal component of the fracture. So we decided before we jump into kind of the technical pearls about it, we wanted to say that our sponsor, Checkpoint Surgical, is hosting a webinar April 22nd on spasticity, and doctors Peter Ree and Kitty Wu will share how their program utilizes nerve and muscle-based procedures for the management of upper extremity spasticity.
To learn more about this course and other upcoming educational programs supported by Checkpoint Surgical, including our own here at WashU, please visit nervemaster.com. Let's go.
Yeah, that's right. Peter and Kitty are an incredible team, and they're going to have a great course. And then obviously, we want to make a little plug for our WashU Nerve course, May 29th and 30th. You can go to nervemaster.com and register there. It'll be fun. So we've decided we're going to do a volar plate. How do you think about where you put your incision? Any pearls about the approach, that kind of thing?
Yeah, I would say, this has been my go-to for more than 2 decades. I really like the approach. I do an FCR approach, so my incision begins at the wrist crease. There's no zigzags. It heads proximally from the wrist crease. Um, and I do look for and assure that I'm not going to injure the palmar-cutaneous branch of the median nerve because it can be, ideally, it's sitting, or typically it's sitting between the FCR and the palmaris, but we all know there are examples where it's sitting above the FCR or in the FCR sheath. So I always am looking for it, but I go through the FCR sheath, retract the FCR, floor of the sheath, sweep, expose pronator, divide pronator, voila, fracture. And that's pretty reliable. Is that your approach?
Yeah, I mean, I think in the setting of a relatively recent trauma, the dissection's been done for you by the fracture. Yes, same thing. The little pearls that I tell our residents and fellows is that as I'm retracting the FCR ulnarly, the tendon itself, when they go through the dorsal sheath, don't follow the retracted tendon. Think about the course of the nerve or the tendon in situ, because otherwise, if you follow the retracted tendon, you're going to find the palmar cutaneous branch. So I'd tell them that, and then after that step, I'll take a freer and just park it over on the metaphysis closer to the fracture, and then just take a sponge and sweep over bluntly, and then put an Army Navy, and then it exposes the pronator quadratus. Are you a, pronator repairer or are you a pronator nihilist?
Um, I would say somewhere in between. If it's not a particularly edematous pronator and it's a robust muscle, I will repair it. I don't think it does much. I'm not convinced. But it just feels right to repair it on your way out. Um, a couple more things that I want to get out there before I forget them. I'm older, so things come and go in my brain. Number one, I'm a Homan fan. So Homan's on both sides. Um, and then there's two nerve related points. I hate to say nerve things around you, but the first is that more ulnar Homan levers on the median nerve. And I have seen what I'm convinced is CRPS from over retraction. And so I always am, working with the team saying, relax when there's a chance to relax and take pressure off the nerve. So that's the first nerve point.
That's why I
This,
use an Army Navy there for that exact reason.
yeah, it's a good reason. Um, the second nerve thing is, we don't think of the median nerve as being at risk, aside from what I just said, but there is one situation where it definitely is at risk, maybe more than one. But the one is that if you have a particularly long fracture, that is one that perhaps starts in the metaphysis and heads to the diaphysis, as you come proximally, and maybe you're taking your scissors and you're splitting the FCR sheath more proximally, you will encounter the median nerve. And so as you head more proximally, there's a convergence of key structures, and you have to be aware of that.
And that's where that median nerve is kind of coming from underneath the epimysium of the FDS and is becoming more superficial. That's the exact point where it's at risk.
Yeah, yeah, exactly.
The other common things that I'll kind of talk about, first off, I don't typically repair the pronator because, people talk about it for plate coverage, but the pronator never gets to where you actually need it to cover. You need it to cover the distal radial aspect of your plate because those are the screws that potentially could tickle and irritate your FPL, and you can never get it there. If you are a pronator preserver, the trick that I learned when I was a resident was if you're doing a BR release, you can actually just split your BR longitudinally and elevate that with your pronator so that you can at least at the end repair BR to BR as opposed to trying to sew into traumatized muscle and edematous muscle, which is a challenge. And then when we're releasing the pronator distally, I typically will tell our trainees um, to cut from ulnar to radial because it's easier to repair the radial artery than the median nerve if they're using a scalpel. Just reminding them of how close they are to the anatomy. They're underneath the median nerve at that point, and any errant kind of when you're taking the scalpel out or withdrawing it from the field, you can get into issues both with the median nerve and the radial artery. And then typically using a kind of a key elevator or I guess it's like a wood handled elevator. It's blue in some sets.
Rasply, that's my favorite
Rasply.
tool
That's
there
it. There
is,
you
the
go.
Rasply.
Thank you for giving me the name, and then elevating the pronator quadratus that way. And then I've kind of sometimes you're trying to move quickly, just making sure that you really get the pronator off because the last thing you want to do is when you're putting in your proximal plate screws and stuff, having to wrestle with getting more pronator off. Just get it done the first time or during the initial round and not having to think about it.
Perfect.
So
Interesting.
then
Go ahead.
go
I
ahead.
was, I was gonna say I do one thing differently. I just divide the pronator longitudinally. I don't create an L-shaped incision. I don't divide it distally. I just divide it longitudinally, put my rasply under it for exposure. I don't release the brachioradialis routinely, but I will if you're having trouble getting the reduction. That typically is because the distal fragment is relatively radial to the proximal fragment. There's different ways to
Hmm.
address that, and that's probably worth mentioning here too. Ryan Calfee taught me, and maybe he taught you as well, that putting a laminar spreader between the ulna and the proximal fragment, and then working the laminar spreader pushes the proximal fragment more radially. And it's not a trick that you need often, but when you need it, it's a great trick.
Yeah, it's great for correcting that coronal shift. I typically try to avoid putting anything in the interosseous membrane, both the Hohmann for the median nerve reasons as well as the laminar spreader, unless I absolutely have to. Although it's a theoretical risk, people do it all the time, of course. I more likely than not release the BR. It's a great teaching point to show the anatomy of the brachioradialis relative to the first compartment, knowing that the BR is the floor of the first compartment, and then showing our trainees this is the BR. It is a flat tendon inserting on the styloid. If you cut this, make sure it's a flat tendon, not a round tendon. And it's really illustrative point because I've almost had a trainee cut the first compartment tendons as we were doing a case. I was like, whoa, hold on, that's round. Do not cut that because obviously it can be tucked into the corner there. One thing that I try to endeavor to do is get a freer or something kind of within the metaphyseal component of the fracture and just kind of jostle it free. No pun intended, but getting to the dorsal cortex, being mindful not to overly manipulate it because you're obviously working in comminution. But that helps free things up. And I try to get the reduction done kind of manually, just with, closed manipulation, traction, flexion of the wrist, ulnar deviation, getting our length and inclination, and then kind of holding for those of you watching, like I'll have my thumb on the fracture itself volarly, and then taking my index finger and getting on the distal fragment, and almost doing like a 3-point mold as somebody else is pulling traction. And then I put a K wire in from the radial styloid and obliquely into the metaphysis just to get my ballpark reduction. And honestly, if that step goes well, the rest is just plating around the pin.
That's exactly right. And I don't always pin, but sometimes I do, or else I will just assure that I have the reduction both visually, and we know that volar cortex is thick, and if you sort of have it, you have it. But I also usually get an X-ray. That requires me radiating myself to see the reduction. But either with a K-wire or with a manual reduction maneuver, that you're done basically because the volar plate makes it so easy. I will say, and I think this has become, there's two other sort of points that I think about all the time. The first is the proximal distal placement of the plate and its relation to the watershed line. And the second is just the plate itself. The plate has 9 degrees of volar tilt of the distal radius built in. And so if you are reducing your distal radius and it's straight and there's no tilt, what does that mean? So let's take the first one first. How do you think about the watershed line and proximal distal placement of your plate?
Well, I think all of these plates are designed to sit at the watershed line and kind of tuck into an anatomically reduced fracture. So it actually plays to both of your points. So that's why I try to endeavor to get it anatomically reduced and held with the pin. And the pin for me came from because when I was operating my first 2 or 3 years in practice, I didn't have a trainee with me. So I just kind of needed to do it myself. And that just was an efficient thing for me. But I think if you get your length and inclination and most of your tilt, at least to neutral, if not a little bit volar, and hold it there with the pin, that plate's going to sit perfectly where you want it, unless there's some huge metaphyseal gap, which sometimes can happen in some of those kind of really osteoporotic bones. You'll have a cortical kind of separate piece that makes it a little more challenging. But yeah, honestly, for most of these plates, some of the newer ones have a different design, but most of the volar plates, it's going to sit right there as long as you're anatomically reduced. And then yes, you can fine tune it with, putting a screw in your oblong hole proximally and adjusting it that way. How do you think about it?
Yeah, I mean, listen, I think we know that if you have neutral tilt, so it's not the radius is not volarly tilted or dorsally tilted, from every functional measure, that's fine. But it's not necessarily fine with a plate that has tilt built in. And the reason I say it's not fine is that that increases the risk of needing plate removal or volar tendon irritation once the fracture's healed.
Right, because those plates aren't designed to sit on neutral tilt. They're designed
Correct.
to sit on a bone that has the anatomic volar tilt.
Yeah, I don't think it's always easy to get volar tilt. And I think it is hopefully easier to get neutral tilt. So it's just something that I have to, I repeatedly think about and state that goal because I've been guilty of having acceptable neutral tilt, but yet the plate ends up being prominent. The second point, again, these are mixed points, but the second point is you're right. The plates are designed to be at or proximal to the watershed line to minimize the risk of plate prominence, but sometimes that's not enough, and you need the plate to be more distally. And you know what? That's fine. And you just need to mention to the patient that we're going to plan on taking our plate out at 3 months or 4 months or whatever the number is. because the plate is too distal and more likely to cause problems.
Right, absolutely. It's just that initial conversation. They may not remember. You'll tell the family the day of, maybe, but it's that first post-op visit where you got to tell them, and obviously document and plan accordingly. I think that in terms of plate placement, oftentimes if I get the tilt to neutral, I'll then take a distal first strategy in which, you could do this with kind of manual holding, but I do like to use a bicortical cortex screw, distally to kind of really bring the plate down to bone and kind of prop the plate up distally and flush to the distal segment. You can do that in a number of different ways. There are some manufacturers that have like a little kickstand device. I take a folded Bovie scratch pad and wedge it in so that it keeps the plate off of the bone proximally, off the shaft, and kind of keeps it levered down onto the distal fragment. Put in that working screw distally, later swap it out for unicortical locking. Yes, you're wasting a screw, but it does have a function and it's serving a purpose. Get all my distal fixation and then allow the plate to help me get that last bit of tilt. I don't think the plate can do all your correction for you, and you will get into trouble if you're, working with somebody who has osteoporotic bone and you ask the plate to do too much. Obviously, if you use a pin, backing out your pin first and then getting your tilt bringing the plate down to bone proximally.
Yeah, well said. That is a technique that I have used commonly for malunions and trying to restore anatomy. So placing the plate on the distal fragment first with all the key points that you discussed. My order of operations for acute fractures is get the reduction, plate on bone, the slotted hole first, which gives me some ability to manipulate it, and then distal screw placement. And to your point, I use a non-locking screw to bring the bone to the plate distally first. Now, hopefully the reduction's pretty much already there, but that non-locking screw in the typical fracture works. Now, if it's particularly common in distally, it won't work. But that is my approach. And like you, I then continue my fixation and eventually change out that screw for one short of the dorsal cortex.
Do you feel that you're able to get the bone down to plate very well with that bicortical screw if you're already fixed proximally? Because I've found that not to be as effective in my hands.
I think if your initial reduction is good, yes. But if you're requiring that single small screw to do too much, then I think I agree with you. So you have to sort of be there and then use it to fine tune that reduction. But
Yeah.
if you're asking too much, no.
Yeah, and I think with putting in that bicortical cortex screw, I am kind of with my hand using my index finger to pull the distal fragment to the plate as I'm bringing that screw down, just to not ask that screw to do too much, typically in osteopenic or osteoporotic bone.
Yeah. And well, I don't know if now's the time or not, but I'll say it now. Arthroscopy is something that I use
Oh God, here we go.
regularly. Yeah, yeah. But what I was going to say is, I think the literature is pretty clear. If you have a good reduction based on C-arm appearance and clinical appearance of that metaphyseal bone, the good volar cortical bone being aligned, an intra-articular fracture is almost always well reduced in those situations, minimizing the need for a dorsal incision to look at the articular surface and minimizing the need for an arthroscopy. There is absolutely
Right.
a role for arthroscopy, in my opinion, in some of these fractures, but for the vast majority, accept your C-arm and accept your visual appearance of the volar bone.
Right. I think it's because the vast majority of these are metaphyseal fractures with intra-articular extension, as opposed to being true kind of die punch fractures, which I think a volar plate is kind of limited with what you can do. So do you, so we talked about using unicortical locking screws, and the reason for that is I think, our group has done some work. Dr. Wall, I think, wrote a biomechanical paper looking at strength of your construct, whether you have unicortical screws or bicortical screws, because the extensor tendons are at risk on the far side. Are you routinely unicortical screws now? Do you ever use a bicortical screw except for that first provisional screw?
No, I like unicortical screws. I don't think it's the end of the world if you drill bicortically, but just under control. I try not to. Yeah, I think for the younger listeners, there's really the flexor tendons are at risk with volar plating, and the extensor tendons are at risk with volar plating. The flexor tendons are at risk because of the plate itself, despite efforts to manufacture plates that have smooth edges, etc. And the extensor tendons are at risk for two reasons. One, either through the insertion process where you're drilling through and irritating tendons, and we know the EPL can be irritated just from pressure and hematoma, so it can already be an unfavorable situation. And then, second of all, if the screws are long, an abrasion mechanism can eventually lead to rupture. So we don't want either of those to happen. And so Dr. Wall, amongst others, demonstrated that keep your screws short of the dorsal cortex, try to avoid drilling through the dorsal cortex, and that'll minimize risk to those extensor tendons.
So as we get into our last couple minutes, I'd ask, do you ever use pegs, smooth pegs, as opposed to screws?
Someone just asked me that. One of the reps just asked me that. So when the hand innovations plate came out, and I first started using it in 2002, 2003, that's all we had. And I think the pegs convert a plate into a fixed angle device. And so there's value there, especially when those pegs are sitting up against that thick subcortical, subarticular surface bone. Um, Nowadays, I don't, but should I be?
But doesn't a locking screw also convert that into a fixed angle device? I mean, I think the people I've heard that like pegs just don't like something tickling on the far end.
I think that's why some people have said, well, if the screw happens to be in the joint, it's better to have a peg. And I'm like,
Don't put your screws in a joint.
don't put your screws in the joint. Easy to say and
Right,
hopefully
right.
easy to avoid, but yeah, but don't. So I do
So,
not.
so to that point, one of the things that I tell our trainees is that I will typically do ulnar-sided fixation first distally and make sure that our intermediate column is stabilized and then check x-rays after the ulnar-sided screws are in to make sure you're not in the joint. Because once you start putting in the radial-sided screws, you'll get confused about whether your other screws are in the joint or not. So make sure those are absolutely clear of the joint. And as you taught me doing our lateral tilt view, it's probably, I think you don't get a regular lateral, you just get a lateral tilt because there's no point.
Yeah, so you want to respect the inclination angles both on a PA view and a lateral view so that ideally you're shooting down the joint surface. And so yeah, for those looking on YouTube, you don't really need a lateral like this. You sort of want a lateral like this. And so you're shooting then straight down the articular surface. And likewise, when you want to respect their articular angles on a PA view as well. The sunrise view can be helpful for assuring there's no dorsal penetration of screws. I think those are hard to get for me. I don't have an easy time of that.
And I don't get it mainly because I'm using unicortical screws. When we're putting those screws in, it's, drilling unicortically and then measuring and taking too short of what you measure. And again, trying to avoid bicortical screws there and bicortical drilling for obvious risks to the extensor tendons.
Yeah, so let's be really clear. Distal radius fractures, I would say the vast majority, if you have this straightforward, I'm going to do X, Y, and Z and these steps, you're going to handle these fractures with a volar plate in a very straightforward manner. That's the beauty of the volar plate. That's why it's such an advance that changed the field of hand surgery. And I really believe that. However, there are a group of fractures that are far more complex, much more difficult to deal with, that aren't so amenable to the easy, quick fix of a volar plate. Yes, a volar plate is part of the solution, but they can get really hard and really challenging, as I know you've experienced.
That's a great segue for our next episode, perhaps, or a future episode. In doing these cases, I remember talking to Ryan Calfee after a hard case. He said, "You got to do the hard ones to appreciate the easy ones." And it's just all the troubleshooting you have to do because all these fractures tend to be a little bit different, but typically are fixed all the same, but have their own characteristics. So, well, I hope you have a great day. I'm going to go run and teach our residents.
Good luck on your lecture, and then I think the weather is clearing. It's going to be a wonderful weekend.
All right, have a good one.
Take care.